Hello everyone, I am Al-Hameed, a PGY3 radiology resident at St. Joseph Mercy Auckland Hospital in Pontiac, Michigan, and today I am presenting a QI study about concordance of internal carotid artery stenosis measurements in acute stroke patients. Is ultrasound indicated after CT angiography? No conflicts of interest to disclose. Vascular imaging is vital in the workup of ischemic infarction. Asymptomatic ICA disease carries a small risk of ischemic stroke. CTA of the head and neck is typically obtained in patients presenting with symptoms concerning for acute stroke. Double ultrasound of the carotid arteries is sometimes ordered after CTA in these patients for further workup. Intervention is usually indicated in symptomatic patients with high-grade stenosis of the internal carotid artery. The purpose of the study is to determine how frequently carotid ultrasound was ordered with or following head and neck CTA in acute stroke patients. Were findings of ICA stenosis between the two studies concordant? If studies were discordant, which study ultimately had an effect on patient management? And to determine overall utility of obtaining carotid ultrasound after CTA in acute stroke patients. Is a retrospective study, analysis and chart review of all carotid ultrasound ordered at the same time or following CTA of the head and neck in acute stroke patients from 2017 through 2019. Emergency department and admitted patients were included, and we excluded ultrasound that were obtained prior to CTA, unilateral ultrasound, ultrasound performed after intervention, ultrasound and/or CTA ordered for reasons other than acute stroke. Reported degrees of stenosis were categorized into mild, moderate, severe, and complete occlusion. The degrees of ICA stenosis were compared between CTA and carotid ultrasound. Results of the study: there were 310 patients who had their ultrasound and CTA ordered in the same encounter. 183 patients met the exclusion criteria and 127 patients met the inclusion criteria. For those who met the inclusion criteria, 80.7% showed concordant result between the two studies, while only 19.3% showed discordant results. We categorized the included patients depending on the degree of the ICA stenosis detected on the CTA. And there was only 7.2% discordance rate between CTA and ultrasound for those who showed mild ICA stenosis. However, the discordance rate went significantly higher for those who showed moderate and severe ICA stenosis. Some demographics about the study as we see here. We further categorize those with a mild ICA stenosis depending on the side. For the left side, there were 97 patients who showed mild stenosis on CTA. And for those, only 9 patients showed discordant result with the ultrasound. Out of those 9 patients, there was only 1 patient who classified as severe stenosis on the ultrasound, which resulted in change in treatment plan and subsequent intervention. Same thing for the right side, 98 patients showed mild stenosis on CTA, 5 patients were discordant with the ultrasound, and only 2 patients classified as severe stenosis on ultrasound, which resulted in change in treatment plan and subsequent intervention. So we have total of 3 patients who were classified as severe on ultrasound and resulted in change in treatment plan. Further review of imaging for those 3 patients revealed significantly poor image quality on CTA due to motion artifact and suboptimal contrast opacification. Discussion: results of ultrasound in patients with mild bilateral ICA stenosis on CTA had no impact on subsequent patient management with the exception of the 3 patients we previously mentioned. Majority of CTA studies were ordered by ED providers. Neurology and internal medicine providers were more likely to order ultrasound for further evaluation. Interventional neurologists typically followed up on the result obtained via CTA with ultrasound when consulted on acute stroke patients. Overall discordance rates were significantly higher with moderate and severe degrees of ICA stenosis compared to mild ICA stenosis, and there are multiple factors which contributed to this variability as mentioned here on the slide. Limitations: small sample size, single community hospital, and variability between radiologist interpreter. In conclusion, CTA of the head and neck is an excellent initial test in evaluating for vascular pathology in acute stroke patients. High rate of concordance between ultrasound and CTA for mild ICA stenosis. And because of that, CTA alone is sufficient for evaluation of patients with mild ICA stenosis. However, this is not the case for higher grades of ICA stenosis with lower concordance rates. Awaiting the results of CTA of the head and neck prior to ordering ultrasound is recommended. Obtaining ultrasound following CTA of the head and neck may be indicated if the CT images were suboptimal. Awareness of the circumstances in which ultrasound is of most utility in the workup of patients with acute ischemic infarction will allow for enhanced patient care and more efficient utilization of resources. Thank you everyone for your attention, and please feel free to email me if you have any questions.